and welcome to Ladies Lunch and Learn. Happy Thursday, everybody. I'm Felicity Homestead. I am host of Ladies Lunch and Learn and CEO at FQHC 340B Compliance. So excited to see you all here.
I'm Lanika Ellis. I am the Director of External Audits here at FQHC 340B Compliance, and it's great to see you guys today.
Hi, I'm Chelsea Violet. I'm the Chief Operating Officer at FQHC 340B Compliance, and I am ecstatic to join this team.
Whoop, whoop, newest co-host. And today,
we wanted to welcome you guys and thank everyone that stopped by our booth at Coalition just to give us good feedback. And we really appreciate you guys stopping by.
Yeah, it was amazing to see everybody at Coalition. So make sure you're introducing yourself in the chat, and we are just so happy. Oh, Crystal, you especially, thank you for all the great hugs. Oh, and you had the reverse preview of what we're going to be doing today. Awesome.
So today we're talking about exploring the integrated pharmacist care model, and we're going to launch our first poll question. And that is always, who's in the room today? Looks like right now we have the majority FQHCs, hospitals coming in second. We have quite a few 340B friends and family.
And a couple other grantees just pulled in. Yay! Awesome. So excited to see everybody. Other grantees, I'm super curious what grantee type you are. And bonus points if you are Black Lung.
Drop it in the chat if you don't mind. All right, so for our fun poll question today is, if you had a day off with no responsibilities, especially no 340B responsibilities, how would you want to relax? Would it be reading, gardening, creating or crafting, hiking or camping, or binge watching? Drop it in the chat or click the poll. For me, it'll be reading. I love to read. If I could just read all day, I would just read all day. What about you, ladies?
I'm reading too. Alex, what about you?
I'd probably be binge watching some show, even though I just finished one last night.
What did you finish?
The Bear.
Ooh, okay.
Hulu. It's good.
Awesome. Megan, what about you?
Probably camping.
Oh, excellent. I like it if you put a GL in front of it instead of the C. I'm a big glamping fan. Chelsea, what about you?
I would garden or camp, but I'd have an audiobook on for either, so kind of a combination.
I love it. And I have a question that's not in the poll, but did anybody over the last month read any of the books that we had on the list of books that were top books from that we were polling people about? Curious. I did do the women. Chelsea, did you do the one that was the Michael Crichton?
I started it. I had 3 other books going and cranked through those and a different unplanned one, and then started the Michael Crichton one.
Awesome. I love it.
I did the same. I started it, but my to be read was very long, so I finished a couple more first.
Amazing. And so many people I'm seeing in the chat were people that we got to catch up with at the Coalition. And it looks like lots of people enjoying hiking and binge watching too. And Risa said the women was amazing.
So our next question before we jump into our guest speakers is, has your cover entity integrated any pharmacists into the primary care team? No, not yet. We've discussed it. Yes, we are just starting, or yes, a while ago. Let's see what we are getting here. We do have some that has started a while ago, so that's great. We have some no's. We do have people that have discussed it, and then we have a few just starting. So hopefully today's presentation will help you guys get it started.
And in the chat, if you haven't started it yet, is it something you're hoping to do? We'd love to know that.
So to introduce our first speaker who will be talking about building a new program, we have Alex Soto, and I will throw it over to you to give us a brief introduction.
Hi, everyone. I'm Alex. I'm following up on all these chat messages. This is so fun. Like seeing everyone chime in. Such a wide variety of stakeholders on, which is awesome. So I am the 340B director. I am in Memorial Healthcare System. We're in South Florida, more specifically, if you know, like the Fort Lauderdale area, that's Broward County. So pretty much that whole south part from a little over past the airport to all the way close to the Everglades. We do have, we're a large dish. We have 6 hospitals. Our flagships are regional and west. So those are our main covered entities. Amongst those, we have multiple child sites of services from oncology, behavioral health, primary care. We then have our Cancer Institute as well. And we're also a sub-grantee to Ryan White. Felicity's nodding because she guided us through some of that as well many years ago. And then how we've set up our pharmacies, we have 7 total, 5 retail, 1 specialty, and 1 home infusion. Those are actually system-owned pharmacies. So for other purposes of how we describe them, we call them internal contract pharmacies because we also have external with, outside parties, outside pharmacies. So it's quite a big operation that we have. I have an amazing team of 13 now, including myself. So they keep us compliant and ready to go, whether it's an annual audit or with HRSA. So I'm extremely proud of the team and the growth that we continue to see. So I'm going to talk about a little bit on how we've expanded our clinical pharmacy program at Memorial and the various things we looked at. So we are very new at this. We are about to finish month 3, so 1 full quarter soon, which is very exciting. But it didn't come easy getting to this point. And we, as I said, we are very conservative. So this has been a project we've been working on for almost 3 to 4 years. So we looked at various things, and first we'll start with, these are physician group practices, mostly all specialists, and they are on the cost report of one of our flagships hospitals. However, with statutory rules and guidelines and where they sit on the cost report, you can't register them for 340B eligibility. But the need of this population and the chronic disease therapy management that they need is intense. So we've started, when we look at their opportunity, sorry, I have all these things to say. When we look at their opportunity of what we were capturing, we do qualify based on continuum of care referral, which is part of our policies. But that percentage was really less than 5%. So the services the clinical pharmacy team would still provide obviously still occurred, but the benefit of what we were able to do for the patients and to expand on 340B was still limited. So we looked at what it would take to move these to hospital-based, putting them back on the ACA license. I mentioned Joint Commission, no matter what, whether, well, definitely, even as provider-based, we always still meet Joint Commission guidelines with our practices. So that wasn't too much of a concern. And then, we then looked at, okay, we know HRSA is not looking to adjust any policies around this with provider-based departments. So what remaining options do we have? And we worked with various groups, and then internally as well with our legal, our pharmacy teams. And we found the best way to move forward was to develop a hospital department inside the four walls of the cost report where these clinics reside in. So in our favor, the 99% of them sit on one. So we created a brand new department, brand new Epic build, and then to meet some other cost reporting regulations, because these would now be a hospital department, they would have to be hospital staff. And because our contract pharmacies are system owned, we then had to move those positions, those full-time employees, over to the hospital department. And I'll go into detail in a little bit on what that looks like. So it was a huge undertaking. The project with Epic ended up being a little bit bigger than I think everyone expected. You know, it's a new model, at least for us. But really the benefits have been amazing. And I do want to highlight on other things our specialty pharmacy also does with benefits investigation, prior auth, copay assistance, and clinical education, which is the piece we'll focus on. But whether we're able to fill the drug or not, you know, even with payer restrictions, we still do our due diligence of the prior auth and the benefits investigation, that if we can't fill it, we then send it to the pharmacy that patient has to go to because they're dictated by their plan, which that's a whole other webinar we can discuss. So much happening on 340B. So it's really a comprehensive service that we provide regardless. And again, you know, there's no fee for this. So I want to start as we launched this, you know, there's many setups that we've seen, but our intent was for it to be completely seamless to the patient, which it continues to be, but also at no cost to them. So for tracking purposes of the cost report, since it is now a hospital-based department, we will be dropping a very minimal charge. It gets written off to be able to report our revenue and expenses. And then internally, you know, we move those dollars around to offset some FTE expenses based on the very small revenue we're getting even out of this initiative. So we do have a little workflow. So the patient will still continue to see their physician as normal in the practice, but at the time they place an order for a prescription, we've built in an automatic referral back to the medication management team. And then the med management pharmacist will have a telehealth. It's usually telehealth. Sometimes there's IT issues. So they'll do a phone call, but all this is documented in the patient's medical record. They'll have a telehealth and do their full assessment. I don't know if I need to get into the full details of that, but it's not just their medication therapy. We almost do like a review of their social determinants of health as well, but their full clinical workup, other issues, and it's extremely comprehensive. It's not just, hey, you're on these meds. Okay, let's look at contraindications. No, you're good. Okay, let's move on. It's extremely, extremely detailed. And it's all also, again, documented as part of that med management encounter. Then ongoing. So obviously these patients are chronic that we're treating. We're just focusing on 2 specialties for now. So there's always a need for ongoing follow-up, which again was part of our standard. And then we'll make sure, you know, we have our annual checkup. So, you know, these 2 parts, the MD visit and the referral, obviously happen at the physician practice. This is via telehealth, but this is where, because the department, you know, within the lines of the cost report, that is an eligible department. It's inside the 4 walls, the way it's set up. So it doesn't have to get registered with Office of Pharmacy Affairs. It then becomes, you know, eligible when those prescriptions are now filled at the specialty pharmacy. So we're only focusing on our internal capture of new patients. We're slowly growing to get refills. And hopefully in the coming month, we will know if we'll be able to expand into other specialist practices. And Lanika, to go back to the question you had, if we had some in primary care, I know you asked the group, but even in our situation with that, a lot of our primary care are already eligible, but we have been opening a few across the community that are not hospital-based. So we are looking to expand that as well. So again, we're just in our baby steps, trying to learn the way. And then I wanted to include for viewing purposes, that referral that goes with the prescription. This is what it looks like of how it's documented. And you'll see that by the little house says ambulatory referral to med management. So on the notes that the pharmacist does, it did not include that. It does say like the hospital, like, regional hospital, medication management department. So it's extremely detailed with all the feedback we've received. We haven't had a HRSA audit yet, but I'm not worried because it's very similar to other things we've been doing, and it's a hospital-based department. So it's been a great journey so far, but I'll let Meg take it on as she's had even more experience at this and from a different perspective.
We had 2 questions pop in while you were talking. We'll have time for more questions at the end, but I feel like if we can, we'll kind of address a couple of them now. So Sarah said, I feel that when I suggest flipping a department from provider-based to hospital-based, there's a major pushback around the patient invoices. Did you get the same pushback? And how are you able to work within that and kind of persuade people?
Yes, so that's the part where we kept the clinics exactly as they were. So we did not move them from PB to HB. We instead created a new department for med management to be done as hospital-based. So we would be considered HB, but we're not charging a patient for this. So there won't be a HB bill to process because we're not charging them.
Super helpful. I know that question comes up a lot, and that's, I think, a big part of how pharmacy integration has played a role. Sorry, there's a fly in here.
No, it's a huge pushback. It's like, I usually get a, now that I've been in this world for so many years, like I think almost 15 years, but that's always like, why can't we just flip a clinic? It seems like the easiest thing to do, but it's not. So
agreed. Having flipped clinics myself is not an easy task, not an easy undertaking. Kelly asked, do you have to look into the scope pharmacists have within the state? And that certainly does vary by state. So you need to look at your Board of Pharmacy regs and what they're able to do. We have some states where pharmacists can prescribe themselves, and that's limited to specific medications or disease states. And then somewhere it's much more narrow and they don't have any of those capabilities. So they really make the recommendations for the prescribers to then follow through on.
We looked into that very thoroughly. The pharmacists aren't rewriting prescriptions. There wasn't a need for that. So there wasn't a need for a CPA agreement. And even in Florida, they're limited to what they can even write for. So that wouldn't have worked with these medications either way. But yeah, that was an extremely important piece to understand and clarify with legal.
When you moved into the 4 walls, was this so you didn't need to wait for it to show up on the cost report? So I think, Kelly, I think that because they didn't change the provider-based clinic to be hospital-based, they were creating a new department, and it was within the 4 walls, is my understanding, Alex, correct?
Correct.
And so that is, so you're not necessarily waiting for it to set up on the cost report, but it wasn't necessarily a matter of moving an existing clinic, but rather creating a new department within the 4 walls. Correct. Did I get that right, Alex?
Yes.
All right, and the last one we've got is there no revenue for the new department that flows to the cost report? So your new medication management pharmacist.
Yeah, so just because we're not charging the patient, because it is our specialty pharmacy, we are moving that's part of the revenue, but it's really revenue to make the FTEs net neutral, more budgeted reasons. So we are moving just a little bit over into that department. So in the cost report, we'll have our expenses from our charges that we're not charging patients, and then the revenue that internally we're moving over, since the pharmacy is the one doing the billing and receiving that reimbursement.
Awesome. Thank you, Alex.
No,
And only 3 months in. So we at some point we may have you come back and do an update on how things are going. But Alex and I, we originally met on mock HRSA audit, and that was early in your program, and you have come so far in how you've developed it out, and it's amazing to see how you've grown it. And next up, we have Meg Rusby. She's the Associate Director of Clinical Pharmacy in 340B. She has recently moved into the 340B role and has spent much of her time developing pharmacists. And Meg's fun fact is that she was a residency in the residency program that Chelsea and I ran. So we're so excited to have her here today and to be able to highlight the model from Meg's Health Center.
All right. Thank you, Felicity. So yeah, today I'm going to be talking about our collaborative visit model that we've developed here at Penobscot Community Healthcare in Maine. So just a quick overview of PCHC. We're the largest FQHC out of the 20 in Maine and the second largest of the 100 in New England. We currently have 16 sites throughout Maine. We go from Western Maine and Jackman down to the coast in Belfast. However, we're primarily located in the Bangor area. In those 16 sites, we have 9 primary care, 5 walk-in care, and then 3 school-based health systems or health clinics now. We service about 58,000 patients, 70% of which are lower income and seniors. And we currently have 375 providers. So pretty large compared to FQHCs throughout Maine, and a pretty big footprint, as you can see on the state on the map there. Within our 4 largest clinics, we have our 4 entity-owned pharmacies, and we currently employ 18 pharmacists. So we have our 3 in our admin team, and then we have our 4 pharmacists in charge. We currently have 8 primary care pharmacists and then 3 that are either per diem or part-time. So of our 8 primary care pharmacists, we currently have 6 that are embedded in our 7 clinics. 5 of our 7 clinics have a full-time primary care pharmacist, and our 2 smallest clinics get 20 hours each from one of our pharmacists. And then we have 1 primary care pharmacist that's dedicated to our infusion center, and then 1 that's dedicated to our controlled substance stewardship group. We also do currently have 2 pharmacy residency programs. We have a PGY1 community pharmacy residency, and then we have a PGY2 community health systems administration. We typically have 4 residents. That's in addition to the 18 pharmacists. And that can vary from year to year between 3 first-year residents and 1 PGY2 or 4 first-year residents, depending on the year. So we have a pretty robust pharmacy system, and that's grown over the last few years. I say few, since 2010 is when we started our clinical services. And so really our clinical services started with a faculty position from one of our local schools of pharmacy, and they initiated with anti-coag management. And then through our residency, and then also continuing to hire additional faculty, we were able to start going from not just anti-coag, but also diabetes. In 2014 is when we really expanded that diabetes and anti-coag. And then in 2016, we were able to additionally add hepatitis C and transitions of care. And so that was the largest disease states we were hitting at that point in time. And then we also, at that point in 2016, had our first non-faculty position, which was really huge as an organization. And the person was not full-time, they were 30 hours a week, but that really enabled us to expand to our 4 clinics that had the embedded pharmacies. Come to 2018, we were able to hire our first full-time primary care pharmacist. And at that point in time, our primary care pharmacist would still work 1 day a week in the pharmacy. That was part of how we were able to financially justify it, and really got the buy-in from our C-suite at that point in time. Additionally, in 2018, through quality metrics, we were able to add in pulmonary function testing as something that needed to be done, which really helped us expand into COPD and asthma. 2019, our chief quality officer at the time came to us and said, "You guys are doing fantastic work, but we need to kind of help revenue some more budget outside of working in the pharmacy." Although our pharmacists really drug their feet in the beginning, the collaborative visit model really started to begin to be developed at that point in time. And then in 2020, COVID hit, so collaborative visits kind of got put on the back burner as our pharmacists were really deployed to help with vaccinations in the monoclonal antibody clinics. And then come to 2021, the push was really put back on. And we'll talk a little more about why in 2021 the push was really put back on. But at that point, we were able to hire 2 more full-time pharmacists, which really allowed us to have the 7 that we have now at 7 sites. And then also at that point is when we really expanded our model from just going off of the pharmacist schedule, but also starting to identify potential visits off of provider schedules as well. And then in 2022, we hired our first practice RN. This was a new model for us as a system. And as of now in 2024, we've expanded our collaborative visits from not just being the pharmacist with the providers, but also our practice RNs and our care management team to also do collabs with our providers, which has helped a lot. So why? One was definitely we weren't able to bill for our services, and that was something we were trying to figure out. So we were able to do that. PCHC also really prides itself on being a patient-centered medical home. So team-based care just is at the center of our mission and how we're treating patients. So this made complete sense to treat the patient as a team. Also preventing provider burnout. So 2021, when we were coming out of COVID, providers were getting really burnt out between desktops and visits. So this was a way that we could really help alleviate some of that burden on the providers was through the collaborative visits. And then also overall improve satisfaction for not only providers, but also patients. Patients really enjoyed, it was one-stop shop. They got to see the provider and patient or the provider and pharmacist all in one visit, got their questions answered, and just really felt they were being better taken care of. So we do have a quick video. And I'm sharing it, right? Okay, just want to make sure before right. And hopefully this will work.
We had some sound challenges earlier.
Anxiety, we know that we can't do all that we're being asked to do and do it well. We have developed collaborative visits with our RNs and pharmacists.
The pharmacist will go in and see the patient first, really do more of an in-depth med reconciliation, make sure everything is accurate on the medication list, there's no interactions. But then also for a lot of the chronic disease states, going over with the patient, what is the best treatment plan for them?
The pharmacist or the nurse does the majority of the visit for us. Almost immediately the pressure was taken off and the patients really like it. It's a time saver and it's helpful. And so when the RNs are not doing collaborative visits, they're helping us with our desktops, they're triaging difficult phone calls. We're constantly.
All right. It worked. So, so as you can see in that was Dr. Mamula. She is one of our medical directors at one of our sites, and she was really one of our provider champions that helped us really roll out our collaborative visit model. So also you could quickly see a visual in that video of how the workflow works for a typical collaborative visit at our organization. So our the provider's medical assistant, I should say, will room the patient like they would if they were just having a visit with the provider, complete the vital signs and do that initial med rec, then go let the pharmacist know that they're ready to go. Let them know if there was any major concerns that the pharmacist will need to know before going in. The pharmacist will go in and they're doing a majority of the visit. They're the ones that are doing the HPI, review of systems, an assessment and plan, and then also the test management. The test management can be either prepping orders for the provider to sign off on when they come in, or for our pharmacists that already have a collaborative practice agreement, they're signing off on the orders right then, as well as making sure that all the quality measures are being met for that patient. And then there will be a quick huddle between the pharmacist and provider in between, and the pharmacist will just tell the provider, hey, this was the plan, this is what we're planning on doing. And then the provider can go in and do a quick assessment, confirm the plan, and then do their documentation. And the vital part is entering billing codes. Part of helping our providers with their documentation, we did create what we call quick texts in our system, so that they could document in the HPI and at the end of the visit. That was just a standard reviewed with pharmacist, or was present with pharmacist and reviewed with patient, and puts their signature and timestamp that they did it. And then how we are identifying them. So in 2021 is when we started identifying them not only on the pharmacist schedule, but the provider schedule. And key things that we would pick off of the provider schedules are any hospital or ED follow-ups, any patients that had chronic conditions that either were uncontrolled or needed more monitoring, like COPD or CHF. Patients that were diagnosed with Hep C or requesting PrEP or good candidates for PrEP. Those were key ones for pharmacists. Also, anybody who had an insulin pump or CGM or was interested in one but may not be seeing endocrine, our pharmacists do help with the most of the management of those. As PFTs, spirometry, as we previously had said, and then also your traditional, if a patient had either polypharmacy concerns or just needed a really good med rec, that was another collab that we would do. So here's just a graph of the growth since 2020 and we implemented, and you can kind of see there's some key things that happened. So in 2021, you see a really large jump because that's when we were able to get up to full current staff of the 7 pharmacists at the time. At the time that I know I said 6 earlier, but 7, that was including me. I was still in clinic at that point in time. So we were split all over the place. And then in 2022, you see a really large jump. And what was key to that is we hired our medical support assistant in 2021 or 2022. And prior to that, our pharmacists were doing all of their own scheduling, rescheduling, referrals. And so hiring that MSA in 2022 to take over a majority of that work allowed our pharmacists to have more time to see patients. And so that is why we had such a huge jump. And then in 2023, just continued growth and then provider buy-in. As of so far in 2024, we have seen just over 1,000 as of the end of June and on track to surpass what we did in 2023. We've definitely learned some lessons since starting in 2020. The biggest thing was communication, getting your team buy-in, explaining why you want to do it, how it's good patient care. Definitely our team changed their tune when they realized it's just more to come at the patient from a team base rather than just a revenue base. So that was really vital. Identifying your provider champion. And that was also really big. The sites that had a provider champion were much more successful than the sites that didn't. And then just working out a scheduling and overall workflow of visits. That one was really difficult in the beginning. There was a lot of confusion on how do you schedule to make sure that it's showing up in billing. we were able to identify that, and I say have a general idea for a workflow. Every practice is going to do things slightly different, but just having a general idea of what works, but then also being able to go back and review that and see if improvements need to be done was really big for us as well. Finding out that some things worked better at clinics than others, depending on the culture of the clinic. That's why we really determined that generalized workflow was much better than like cookie cutter for each site. And that was mine. So.
Thank you so much, Meg. That was wonderful. Okay, so we have a question that came up from Kayla. It says, since pharmacists have rendering care provider status in the state of, Idaho, I'm in Ohio, and I almost said that. In the state of Idaho, they are able to provide managed care and some acute care clinical services and bill for them. One of the struggles we are having as we try to integrate our pharmacists into our clinic is training our medical billing staff on how to credential pharmacists and bill for their services. Do you have recommendations on how or where to have them trained on billing and credentialing pharmacists specifically?
So that one I can't really answer because we're not really doing that yet. It's still all under the provider because we're doing the shared visit. We are currently in communications with our Medicaid for Maine on billing for pharmacists. So I probably will have a little more hopefully within the next year, but I can't speak to that right now.
Yeah, and where Megan is in an FQHC, they have different billing requirements from other care settings that limits whether or not pharmacists are reimbursable. So that adds another challenge. So awesome. It is so wonderful to hear from both of you.
We have another question that came in, and it's around using Athena. And I think we had in Seaport back in the day, they used Athena before they rolled over. And I think I can't remember if they had incorporated the collaborative visit models there. So maybe you can speak to this too, Meg, but they had discussed using this model, and another clinic said they had attempted to implement the co-visit model, but Athena would not allow both the pharmacist and the provider to document in the same encounter and be distinguishable as to who documented what. Do you have any advice or experience about that?
So I want to clarify, so I'm assuming they're talking about Athena 1. We have Athena Practice. We're switching to Athena 1. So Seaport to my knowledge was not able to successfully get that up and going before we switched over to Athena Practice, before they switched over to Athena Practice. However, I know we brought it up when we met with the people from Athena 1, and they seemed like they could probably help us figure out, but we've not started that transition yet. So I don't have answers for that, but I can keep you posted as we move forward.
And then Meg, a question for you, because Chelsea and I preemptively answered it in the chat, but maybe we were assuming because we were answering it based on our knowledge previously. Yeah. Is the rest of PCHC still on GE Centricity, or is everything on Athena now?
So GE Centricity is now Athena Practice, and we're all switching over to Athena 1 in 2025.
Okay. All right. There we go. Okay. So. Yeah. Troy, there's your answer.
All right, so we have another question. How long are the visits that you have, Meg? How much time is allocated to the pharmacist versus how much time for the providers?
So it depends on the type of visit. So I'll start with our spirometry visits because those differ. So for our spirometry visits, that is allocated an hour because we do pre-post bronchodilator. So that is an hour on the provider schedule, and then it's on the pharmacist schedule, hour on the pharmacist schedule, a half hour on the provider schedule, but it's offset by half hour. So the first half hour, however, the provider's only going into the visit for maybe 10 minutes at the end of the visit, whereas with all other visits, we are scheduling for 30 minutes on both provider and pharmacist schedule. But like I said, a majority of that is being done by the pharmacist, and the providers may be going in 10 to 15 minutes, depending on the visit. So
awesome, thank you. All right, I want to think Ohio Medicaid has put together some materials on credentialing. Maybe there could be some general information from them that would be helpful. So this would go back to maybe Troy's question. Sorry, I'm trying to look. Oh no, Kayla's question. So Kayla, regarding your questions around credentialing, maybe reach out to, if you have contacts in Ohio, reach out to me if you want, or research just kind of the Ohio Medicaid pharmacist credentialing stuff and see if they have something that might be helpful to you there. Thanks so much for offering that up, Max.
Yeah. And if you're in Pennsylvania, that state has just passed a lot of new opportunities for pharmacists for billing as well. So that's look into your state opportunities if you haven't already.
Agreed. All right. I think we have answered all the questions that have come in so far. Please feel free to keep throwing them in there. I'm going to bring our slides back up and roll into hot topics. So if you're as exhausted as I am and thinking, why, what happened? This has been the last 2 months. These are all the manufacturer restriction updates and new restrictions that have rolled in. So our brand new ones are Bausch and Lomb, which applies to all covered entities. You get one contract pharmacy if you don't have an in-house pharmacy or an entity-owned pharmacy, and that's within 40 miles. And this fly is going to be the death of me. And you can designate that pharmacy on 340B ESP. And then we had, at the end of June, we had Vertex, and their restrictions only apply to hospitals. If you don't have an entity-owned pharmacy, you can designate one contract pharmacy on 340B ESP. And then on July 1st, when really everything hit the fan, that's when I felt like all these dumpster fire dogs down here just came into their full, like, yeah, they're just living their best lives. Viatris applies to hospitals and health FQHCs, CHCs. And if you don't have an entity-owned pharmacy, you can designate one contract pharmacy on 340B ESP. I'm not going to go into all the specific updates, mostly because many of the updates were about state protection exemptions, which is fantastic that these keep rolling along, which is great. Obviously, not all manufacturers are respecting or acknowledging those laws right from the get-go. We've seen with Arkansas, that was the first one. And we've seen, after kind of some prolonged litigation, more and more manufacturers coming on board. We've now seen some of the new manufacturers that have introduced restrictions right from the get-go say that any states that have passed legislation have exempted them. Jazz kind of made their life easier. They just said anyone that's passed it, we respect it, go for it. Bayer requests that you contact 340B ESP if your state has passed legislation, which is an interesting approach. And then we have some manufacturers that are permitting kind of full pricing restoration for the states that have passed legislation, but they are requiring you to submit claims data through 340B ESP again in order to regain kind of your carte blanche 340B pricing access. The only exception is West Virginia. West Virginia's law, man, props to whoever was part of that conversation, because the penalty for each transgression is monstrous. And so manufacturers don't want to touch that. So even for the manufacturers that are requesting or requiring contract pharmacy data to be submitted, the West Virginia law has kind of alleviated their need to do that. I do have down here AstraZeneca, Bausch and Lomb, Exelixis, Gilead, Incyte, Johnson & Johnson, Sobi, and United Therapeutics have not publicly disclosed any state exemptions at this time. We have seen a number of manufacturers not necessarily put out a formal notice that they are exempting covered entities in a state, but if a covered entity has reached out and said, we have this law that was passed, are you providing access? We've seen some soft or quiet exemptions permitted.
Yeah. And if you are not told, your wholesaler should know if you have access, but it doesn't make it easy.
And an important thing to know there is that wholesalers cannot provide access to the 340B price until the manufacturers release it for them to do so. So while this is an incredibly frustrating process, especially if your state passed a law and you're like, yes, I get all my pricing back, and it's not happening, acknowledge that the wholesalers are not the villains. they can only provide access to the pricing that they are given to give access to on.
Yes, yes. That Crystal is from one of the wholesalers.
Yeah.
She appreciates that messaging.
Yeah.
Awesome. All right. We'll jump in.
Elizabeth, thank you. I'll add that to my list. I'm sorry, I missed one. I was trying to grab all the updates that came through, and I missed Kansas for BI. So I will add them in. Thank you.
Awesome, thank you. So just to talk a little bit, we're having a lot of lawsuits. So every time a state introduces a contract pharmacy protection law, then we will see in very short order some or 1, 2, 3 manufacturers introducing lawsuits. Perhaps pharma is introducing a lawsuit on behalf of their membership. And so it's all part of the process of moving that state legislation forward, because as we saw in the Arkansas case of them introducing their legislation, originally we really didn't see manufacturers responding to it by removing their restrictions until they saw that the state was willing to enforce that law and that the state was actually serious about the law and implementing it. And so as the lawsuits are litigated and as we have success in the lawsuits, there's a couple things that are happening. One is it is creating precedents and case law that is supporting other lawsuits that are happening in the states. So this is as long as we continue to have positive success in these, it means that we have increased likelihood for each of the lawsuits that goes forward for them to look at the precedents that were set in other states. And essentially, if a similar or the same argument is brought, then they will likely rule this in a similar or same way than they did in a previous case. But pharma is also, and the manufacturers are also looking at alternate arguments as they bring each of these cases. And so in this AbbVie case that we're still in the process of, there is multiple manufacturers that filed in Mississippi, and the courts have asked for them to be joined together so that it's not hearing multiple cases. So essentially they said, we want to make sure that the ruling that we give back, because essentially, even though you might have some variance in your arguments, we want to make sure that the ruling that we give back on the law is consistent with the law so that we're not getting different rulings from different courts within the state. We want to give you one set ruling for our state. And then, so they brought all of the different cases together. And then in that, the different manufacturers asked for what's called a preliminary injunction. And that would say that if they got that preliminary injunction, then the state would not be able to enforce their law until the end of the court case, and when a ruling was reached either for or against. And so if there was the preliminary injunction, everything would stop until the ruling came out. So in hearing the evidence, there was a few different arguments the manufacturers put forward. And it's a really interesting court case. The preliminary ruling that we have is the document is not it's not a refined document. It's a very rough copy, so we did not share that with the group today, but our hope will be to have something that is shareable for next time, because it's definitely worth reading. And so there were a few different arguments that we've seen. And so we've seen the manufacturers arguing things like there's not a place for the state to be involved in 340B. And so the argument about what they call a preemption clause, and so that because this is at the federal level, states shouldn't be involved. And the court overrules that and says no, because they don't discuss distribution in the statute, and because the regulation of pharmacy and distribution happens at the state level, it's appropriate for it to be here. They talk about a few other different arrangements in it that the pharmaceutical manufacturers believe to be inappropriate. The state court comes back to the intent of the 340B program to help covered entities stretch scarce federal resources. So the court talks about the program being for both helping access medications, but also to help strengthen the safety net. So that's a really positive piece. But what was an interesting and new argument that was in this case is the question of whether or not the replenishment model, which we use all across 340B, would be considered potentially unlawful and potentially diversion. So if you think about that in the grand scheme of things, beyond just contract pharmacy, that would have implications all over the 340B program. Every mixed-use hospital, any entity-owned pharmacy that was operating on a virtual inventory, if your clinic-administered drugs were on a virtual inventory, this would have had huge implications. However, the Mississippi courts reviewed all of the evidence that was provided, reviewed the operations of the US pharmaceutical system and how pharmaceuticals operate in our country, not just how 340B operates, but how does distribution of pharmaceuticals happen in our country, and said that not just is replenishment model okay in 340B and not constituting diversion, but the replenishment model is just a normal natural occurrence within the pharmaceutical delivery system within our entire country. So they denied the preliminary injunction request. Just adamantly, they said, none of your arguments that we have reviewed do we believe we will rule in your favor on at this point in time. So we're not going to give you a preliminary injunction. Huzzah. And so they still have to go through the process of doing the court case. But the fact that they've already come out and said replenishment model is not unlawful is a huge success for the entire case here, but also for the entire country, because if they were able to start pulling apart replenishment, that would be a huge disruptor for 340B. So that's all we're going to say about that, except for way to go, Mississippi. You guys are doing the Lord's work. You are team awesome.
Felicity, before you jump into ADR, sorry, lost my spot. Max said, might the manufacturer start tracking serial numbers and try to tie them to distributor and covered entity? And while I did not make a slide dedicated to the BMS FAQ, I'm wondering if maybe you want to speak to that. I can actually share my screen. I have information from our newsletter on it.
Yeah.
If you want to start talking, I'll share my screen.
My favorite number in the world is 27. And that is also the BMS FAQ in their most recent update that ties to exactly what you are saying, Max. And so BMS, Bristol Myers Squibb, went to 340B ESP and requested enhancements to their system. And those enhancements include a number of fields that we have never been asked for before. And when BMS had people go in and reattest in 340B ESP, they committed to providing this information when ESP is updated to be able to accept it. And so there are a number of fields that would be included in that, but the most concerning of those would be the BIN PCN group number, wholesaler invoice number, and then the serialization information for a product under the DSCSA. And it is BMS's expectation that products would be replenished within 14 days, and that all of this information would be provided to BMS at the time of data submission. And in that statement, it also suggests that failure to present each of these lines of information completely would mean loss of access to purchasing their medications. So there's a significant challenge that is presented with this, because unless an item is dispensed in a full package size, then it's going to be very difficult to replenish it at a 14-day window. And even if it is a full package size, maybe difficult to replenish at a 14-day window. So something to be aware of. We've started having
I did
conversations.
copy and paste that information into the chat. I thought that was easier than me sharing it on the screen.
Thank you. We started having conversations with some of the major chain pharmacies where this will likely be an issue. There's one chain in particular that doesn't share BIN PCN group, that you could see that that would be a significant problem. So this has already been put on that chain's radar, but this could come as soon as October. So just be aware. And then we don't have a lot of time left, but just, I won't go into all the information on this slide, but just FYI, in June, the administrative dispute resolution process came live. We do not have the ability to sue the pharmaceutical manufacturers when they fail to provide us access to 340B pricing, because of the way the 340B statute is written. The only group that has the direct opportunity to sue is HRSA, to the pharmaceutical manufacturers, because of the way the 340 statute is written. Our pathway is through the administrative dispute resolution process. This walks through what that pathway looks like, which is essentially, this is an overview of the ADR. Important pieces in the changes are the new panel is made up of OPA employees. They've reconstructed it to make it more accessible to the covered entities. And once you've filed all of your documents, they have committed to getting you a decision back within a year. And then this is the process of going through it. They do expect everybody to work together in good faith, to submit documentation. OPA will review it. And then if OPA approves you for the ADR, they will load everything into OPACE, your OPACE user account, and then they will alert the other party that they are now in an ADR process for them to be able to respond, and they will move you through it. Nobody has to show up in person to OPA. So everything is done very much by submitting data to OPA. So you don't have to worry about going and arguing against pharma's lawyers in person, just on paper. So there's that.
3 minutes left. If anybody has any more burning questions you want to drop into the chat.
Yeah. And just thank you, Alex and Meg, for being here. You guys did an awesome job presenting. And just from the conversation that we were seeing in the chat, it's clear that people are really interested in getting pharmacists involved in their practices. And I love just having sort of the very experienced and just getting started, because I know it's hard sometimes, like, how do I get started? Or, like, what could that lead to? So it's great to have both ends of the spectrum.
Kimber, your question is about BMS also mentioning credit replenishment, and BMS has stated that they rely on covered entities to work with their legal counsel to determine what does and does not meet the requirements given by BMS. But I think that you can look to the case that Felicity was just talking about, where the preliminary injunction was turned down, was declined, because a replenishment model is not deemed to create diversion. So something you definitely want to talk to your legal counsel internally, potentially if you have external legal counsel, work through that. But also important to maybe bring in that recent decision to decline a preliminary injunction as part of that discussion.
And you want to go back and look at the attestation that was in 340B ESP because that's where it was signed. But I believe that the language was something to the effect of a non-transparent distribution model. And so we had a conversation around this with the manufacturer where they said that they could not tell us which ones were and which ones were not, but that it was up to the covered entity to seek direction from their legal counsel about what is and is not considered a non-transparent model. But again, I agree with Chelsea. See that legal decision, and again, we'll share a version of that is readable next month.
I've got one more question in here we can toss in quickly. Thoughts on putting in complaints through the state for those with state laws in effect before going through the ADR process? I would,
100%.
yes, I would
100%.
say definitely go for it.
Yes, yes, leverage your state process first. That is absolutely, and it's important to understand your state law and how it works. Kansas, your state law is a little bit different because you are required to go through the patient advocacy, or it's a patient board. And so you actually have to show how the loss of 340B access impacted your patients. And so it's a little bit more than some of the other states than just showing I lost access to this medication. You actually have to be able to demonstrate a patient harm as well. So as you're gathering your documentation for your state submissions, make sure that you understand what your state requirements are.
And I don't think it's in this slide, we have it in a different handout, but it does explicitly state in the ADR information that if you are pursuing things underneath your state law, that's outside of the scope of ADR. ADR is federal and they can't enforce state laws. So if it's through your state law, you got to go through the state.
Awesome. Thank you, ladies, for being here. We look forward to seeing you next month, where we're going to have Hannah Rowell from Draft and Tucker, Linika, who lost her internet, that's why she disappeared, and Chelsea are going to be talking about clinic-administered drugs and self-auditing. So it'll be a great topic that is something that we can always learn more about. So have a wonderful rest of your day, everyone. And thank you, Alex and Megan, so much for being here with us. Hi, everybody.